My dear viewers and friends, in this video, I am going to talk about the role of immunomodulatory therapies in sepsis. It is a very common topic, and questions are often raised both by beginners and relatively experienced intensivists. And it is often a matter of discussion that when we should start, if at all we do, start the immunomodulatory therapies in sepsis, whether it should be early or whether it should be late when all other therapies have failed, or whether we should not at all start it. Now, there is considerable debate, and the evidences which have accumulated so far have been interpreted from different dimensions and from different perspectives. So, this is only a very short bird's eye view of the pros and cons of such immunotherapies and when they can be useful. When we talk of immunomodulators, we include three classes. They can be either immunosuppressants, they can be immunoadjuvants, or they can be immunostimulants. Immunosuppressants have role when there is active inflammation where the body itself causing harm to its own self as a result of unabated inflammatory reaction or response. And when we use immunosuppressants, they can be either specific or non-specific immunosuppressants to suppress the immune system, and particularly they are useful in the treatment of autoimmune disease in organ transplantation and anti-rejection. So their role, pure immunosuppressant's role in critical care seems to be restricted unless and until the patients do have features which are suggestive on account of pure immunosuppression. The second class are the immunoadjuvants, which also have non-specific actions, and they improve the immune responses to an antigen. So, if that antigen is truly foreign, then it mounts an immune response which is of benefit, or which causes a benefit to the body and preventing its harm. And if it is a self antigen, then also it abates the immune response, and thereby it has a protective action on the body by inhibiting such unwarranted immune responses to a self antigen. The third category are the immunostimulants, which are specific or non-specific. The immunoglobulins are also sometimes included, but otherwise we have the immune checkpoint inhibitors also, and the Janus kinase inhibitors, the JAK. So they are basically stimulating the immune system. Their role has been usefully considered in many cases of malignancy, but they're also useful. They have been found to be useful in sepsis in many studies because they enhance the defense mechanism of the body, and they're used in the treatment of inflammation and cancer. Even IL-1 antagonist belongs to the same category. So the question is that what are the immunomodulators in sepsis which have been used pragmatically, and which with certain amount of uh, certainty about their action. Now, this can be categorized into these 10 types: immunoglobulins, the mesenchymal stem cells, though they're relatively new, the colony stimulating factors like the GM-CSF and the GCSF, the complement inhibitors like the C1 esterase inhibitors, the Janus kinase inhibitors, which is relatively again new, the corticosteroids, cytokine modulators, monoclonal antibodies, uh, toll-like receptor agonist, antagonist, although they are much though still in the experimental phase, and the phosphodiesterase inhibitors also. Now, among them, if you see, only two or three therapies have been found to be useful in good number of diverse studies in multiple clinical settings. Otherwise, many of these have been found to be useful in very limited scenarios. So some other immunomodulators can also be added to that list, including Fab antibodies. But the question still would remain that whether they can be used as a rule of thumb or not. And the answer so far is that they can't be used. So probably with the evolution of precision medicine, some of them would find good use in specific scenarios. But till that time, we have to restrict our use to a selected two or three or maybe four. Let us look into this case. A 35-year-old male, acute febrile illness with AKI and septic shock for 7 days, is admitted in the ICU. Patient is on mechanical ventilation, on volume control mode, hemodynamically unstable, on triple inotropes, also undergoing CRRT. The TLC count is 30,000, predominantly lymphocytes. Mind that it is not neutrophils. The PCT is 50. The ABG shows metabolic acidosis with a high lactate. Chest X-ray shows bilateral consolidation with pleural effusion. Ultrasound abdomen shows a normal IVC diameter of less than 2, and the distensibility is less than 20%. The tracheal culture is positive for MDR Klebsiella. The blood culture is positive for multi-drug resistant or carbapenem resistant Acinetobacter. Patient is currently on meropenem, poly-B, targocid, minocycline, caspofungin, and hydrocortisone. Now, if this is a patient, uh, in this patient, at what stage of the illness should you consider using immunomodulators? Now, this is the question which sometimes confuses many clinicians, because some may think that we won't let it go to this stage at all, and we can use immunomodulators much early, because as it has been said that some of this immunomodulation process occurs very fast, and when intervened early, particularly during the pro-inflammatory phase is active, at that point of time, if the intervention is made, that becomes much more effective than when it is intervened at a later stage, because at a later stage immunosenescence sets in and followed by immune paralysis, and in that stage, it is very difficult to expect that even if the drug is useful, it will have such a strong or incite such a strong effect on the immune response, because there is already immune paralysis. So the receptors are almost deactivated. Now, if you see the role of steroids in septic shock and in sepsis, you have seen that this course of the use, the evidences which have been gathered since for past 50 to 60 years, has been largely fortuitous. From starting from 76, when we see the Schumer reported that the prospective study showing a mortality rate of 38% in 86 saline treated patients compared with only 10.4% in 86 steroid treated patients. And it showed a mortality of 42.5% in 160 patients without steroids compared with 14% in 168 patients treated with steroids. So it showed large benefit in the patients when they were administered with steroids. But things suddenly started changing from the mid 90s and later in the early 2000s, when it more distinct studies, well conducted studies found that there was minimal benefit with the use of steroid. Particularly, this was clearly shown in Cortica study, which showed no difference in 28-day mortality between 50 milligram hydrocortisone IV every 6 hours for 5 days and then tapered compared to a placebo. But there was one thing that came into notice, that faster resolution of shock and the lesser requirement of vasopressors was observed in clearly across all the studies. Now, whether that led to an improved in the outcome was still not clear. After that, with time, we came into around 2016 and 18. We had two good studies, the HYPRESS and APROACHES. And in APROACHES study, the 90-day mortality was lower in the hydrocortisone plus fludrocortisone group compared with placebo in around 1,241 septic shock patients. So, and also not only that, they also had a faster shock reversal, and although they did not have any difference in the ventilator-free days. So even before that, in high press, also continuous infusion of 200 milligram of hydrocortisone for 5 days, followed by a dose tapering until day 11, or either 11, did not prevent the deterioration of sepsis into septic shock. So that was the situation, that the immediate effect was still not clear, that whether in patients it need to be used. But some clarity was achieved in adrenal study, where again no significant differences in 90-day mortality with continuous infusion of hydrocortisone 200 milligram per day for 7 days was seen. But the same thing, it was also seen that there was a shorter time to resolution of shock, and therefore its use continued. And when we looked into the later stage in 2023, the Piratio and the Bosch, Piratio was a patient level meta-analysis where it was seen that when hydrocortisone was combined with fludrocortisone, there was a lower relative risk of mortality compared with hydrocortisone alone. And although there were no significant reduction in 90-day mortality of hydrocortisone compared to placebo, and no difference secondary outcomes except for vasopressor-free days. So we can see that, and Ben Bosch was a retrospective cohort study in some 88,000 plus patients, where it was seen that septic patients with norepinephrine who received hydrocortisone treatment, the addition of fludrocortisone was associated with 3.7% lower adjusted absolute risk difference in primary composite outcome of mortality or discharge to hospice compared with initiation of hydrocortisone alone. So there were some studies which were not equivocal, and some of the studies although pointed out to the benefit, but they had their limitations. But one thing that was common was whether there was any difference in outcome or not. The resolution of shock, or the shock reversal that we say, was definitely faster with the use of steroids. So what is the position on the current use of corticosteroids in sepsis? Yes, they are useful and they should be used in patients with on septic shock for shock reversal. Whether their use can be continued after reversal of shock, there is still certain amount of uncertainty, but proponents do use it for a considerable time even after shock reversal. But of course, when that is patient improves further, then one should stop the corticosteroids as much in a way that they taper or bring down, stop the use of antibiotics, etc. There are certain theoretical benefits of steroids in sepsis because you have the increased number of sensitivity of alpha and beta adrenergic receptors, decreased release of adhesion molecules, increased transcription of anti-inflammatory cytokines, decreased transcription of pro-inflammatory cytokines, inhibition of arachidonic acid, inhibition of platelet activating factors, prevention of neutrophil aggregation, and inhibition of inducible form of nitric oxide. So all of these are potentially theoretical benefits which are potentially useful in patients of sepsis. The next question comes that what is the role of ulinastatin, which we have often used in our day-to-day practice for treating patients with sepsis or septic shock? Although this drug was initially used for acute pancreatitis and it was found to have some benefit in acute pancreatitis, later it was used much more aggressively in patients with septic shock, and it is still being used. And most of the studies which are the literature is available supports its use, and this concludes that ulinastatin improved all-cause mortality and other related outcome in patients with sepsis or septic shock. And this was evident in meta-analysis. Only the thing that was important is that most of the studies were conducted in a particular geographical setting in China, and all of them were positive studies. So that raised a few eyebrows because those studies could not be reproduced elsewhere. So if you see the different studies in the meta-analysis, there in the ulinastatin group has been favored in a large number of these studies. Although I said that as such, these studies were from China to a large account, but even then, we can see that bearing one or two studies which are too close to the midline on either side, almost all other favors the use of ulinastatin. Now, ulinastatin is effective in reducing mortality for critically ill patients. So this was something which raised many eyebrows, but also gave confidence to the users because it was a causal mediation analysis, which is slightly considered to be a better form of statistical analysis than post hoc, where it was found that the use of ulinastatin was associated with reduced 28-day mortality rate in critically ill patients with sepsis. However, ulinastatin was associated with increased length of stay in ICU and hospital, and the medical cost was also increased. Furthermore, 35% of the total effect of ulinastatin can be explained by the reduction in CRP, consistent with the anti-inflammatory effect of ulinastatin. So all of these seems to be a favorable response to the use of ulinastatin. So if we ask that what is the position of the use of ulinastatin in sepsis, we need to understand that most of the studies done in the recent times supports the use of the ulinastatin, but as you said, that ulinastatin needs to be started early before immunosenescence or immune paralysis sets in, and therefore it can be effective only if used sufficiently early, so that those maximum time of those 3 or 5 days the patient is should be free from immune paralysis. Another important area on which there is a lot of discussion are the extracorporeal blood therapies, purification in sepsis. And many a times, along with CRRT, such cartridges, which are meant to remove the cytokines in patients with sepsis, are useful. But we also have to remember that many a times that along with the removal of toxins, the cytokines and the inflammatory residues, they also tend to remove the antibiotics, nutritions, supplements, and a lot of other things which can be deleterious or harmful for the body. If you see the basic processes of blood purification therapy, then we have to understand the targets. Targets is to remove the pathogens from the blood, remove endotoxins or other pathology associated patterns, then removing activated leukocytes or reprogramming leukocytes and reducing the cytokine blood levels. So all of these actions have some or more influence on the overall outcome of the patient. But there seems to be a lot of unanswered questions, like the question concerning the optimal length of use remains unsolved. And also, it remains to be answered that which patients will benefit most from the treatment so that it can be offered on a selective basis. The timing of RRT initiation for AKI is unanswered and largely a debated question. And there has been no clinical study which has focused on the loss of antibiotics and micronutrients during CRRT using a highly adsorptive hemofilter. So once we have these queries get settled, probably it will be more useful to draw an infusion, to draw an inference. So if I say that what is the position of the use of cytokine removal therapies in sepsis, well, I can say that there is no evidence on the use, and there are evidences that it can be harmful. So whenever cytokine removal therapies are adopted in critically ill patients, they should be practiced after sufficient takings after proper counseling, and all the good things should be also taken with a pinch of salt. Again, another important drug therapy which has been used in these patients is the IgM enriched immunoglobulins, which can improve the microcirculation in sepsis. So the pilot randomized trial had shown it, and the same was not reproducible in some other studies which were conducted after a year or two of this initial study. But both studies had their own deficiencies and limitations, and so it's not expected that the patients on whom they administered pentaglobin would behave in a definite predictable way, and so it was not meant to be. A 72-hour infusion of IgM enriched immunoglobulins, that is pentaglobin, in patients with sepsis or septic shock may be associated with increase in the sublingual microvascular perfusion, and thereby it can improve the hemodynamic status and also overcome the vasomotor paralysis. Now, the changes in the sublingual microcirculation and the near infrared spectroscopy derived parameters, they have been used. And there are a lot of minor differences which cannot be assumed for the purpose of clarity. But I'm definitely that when we have large studies or a few average, middle to average studies are combined, this will become more meaningful to us. So what if we ask that what is the position on the use of IgM enriched immunoglobulins in the sepsis? Well, we can say that there is definitely whatever evidence exists about its usefulness, that has a basis, and that is not backed with lot of theories, etc. That is a genuine concern. Another important drug which have been marketed is the thymosin alpha 1, which is an immunomodulatory treatment for sepsis. And this one is again a review of randomized controlled trials, which looks into the efficacy of this drug. And it can be seen that this thymosin alpha will be beneficial to septic patients in reducing mortality or modulating the inflammation reactions. However, the quality of evidence supporting the effectiveness is low, considering the small sample size and inadequate adherence to the standardized reportings guidelines for RCTs among the studies that were included under them. So, therefore, we can say that the efficacy of thymosin alpha as an immunomodulatory treatment for sepsis is still under debate, and we need more studies to either confirm or to refute it. Now, as it is also known that it acts, this drug, thymosin alpha, acts as an endogenous regulator to both the innate and adaptive immune systems. So therefore, if it is found useful, then it can handle both the immune systems, and it is used worldwide for the treatment for diseases associated with immune dysfunction, which includes viral infections like hepatitis B and C, certain cancers, and in septic patients. So if you say that what is the position on the use of thymosin alpha in sepsis, I can say the initial reports are very promising, and it is likely to become an important addition in the armamentarium of the intensivists for treating sepsis. But we need more data to come to confirmatory response at this point of time. Besides this, there are polyclonal and monoclonal based antibodies, and they are also being tried as potential therapy for treatment of sepsis. And they also follow the same rule that they should be used early before immunoparalysis or immunosenescence has set in. And most of the studies indicate no significant change among inter and intergroup comparison. But they also say that further studies are needed. And among the studies that are available, there has been increase in survival rate, ventilator and ICU-free days occasionally, but not in a very systematic manner. And they have their effect on almost every organ system. They have systemic effect like multi-organ failure, peripheral edema, pyrexia. In the lungs, there can be respiratory distress syndrome, pleural effusion, pneumonia, dyspnea, and likewise in the gastrointestinal, skin and bone, brain and neck, heart, everywhere they can leave their footprint. So, what is the current concern about the role of MABs in sepsis? Well, the lot of research is underway, and we hope that very soon it will come into the foray and it will be able to reduce a lot of complications that are accounted for not using the drug, using the alternatives. Now, maybe after MABs become available, we can take over more information about their benefits or situations where they are likely to cause benefits. So, my key messages at the end of this video would be that sepsis induced immune dysregulation and its long term effects on morbidity are poorly defined. Sepsis leads to impaired functions of the innate and adaptive immune systems, and the exhaustion of T cells, reduced expression of HLA-DR on monocytes, and induced uncontrollable apoptosis of immune cells are hallmark features of sepsis. Furthermore, several new therapeutic agents for sepsis, including MABs and anti-apoptic agents to reduce the T cell exhaustion, immune cell apoptosis, etc., have been used with variable amount of success, but key benefits are still not clear. So it can be said that no specific immunomodulatory drugs or immunotherapeutic adjuncts for the treatment of sepsis are available till the current date. But at the same time, we are hopeful that new immunoadjuvant therapies will come and they will show more benefit than what was seen with the others, with the predecessors. So thank you.